Hello, hello. Welcome to CPC on this fantastic Halloween. And welcome online to all of our applicants who are Zooming in as well. CPC is something, it's the Clinico-Pathologic Conference. We do it every Friday here with the IM residency program. The goal of it is to kind of have interesting cases that we talk with one of our expert discussants about. And we kind of get to hear their thought process as we go through the case. So, starting off, no disclosures. So, the case today is a 38-year-old male, history of alcoholic cirrhosis, presenting with epistaxis, gingival bleeding, and lower extremity swelling. And our expert clinician is our favorite Bryce Montane. So meet the expert. Dr. Montane grew up in Tampa, Florida. He did medical school at the University of South Florida through the 7-year MD medical program. He then did his internal medicine and chief residency at the Cleveland Clinic, where he met his wife. Then came here to WashU to do a postdoctoral fellowship in Masters of Science in Clinical Investigation. Currently, he's an assistant professor at the Department of Medicine. He's core faculty for our intern journal club, an assistant director of the internal medicine clerkship, and teaching attending for ambulatory and inpatient. You want to talk about this? You want me to?
Hello, hello. Cool. Number one, if you saw the little bobblehead, that's good. I did not make it. I did not make a bobblehead of myself. That my parents have a good sense of humor. Number two, before I forget, if you were in Dr. DeFur's co-clinic today, I may be a little bit late because this thing ends at 11:15. Okay. So why wash you? If you had if you had put a gun in my head and said pick an organ whenever it came to subspecialty, I probably would have picked cardiology, which was very common for someone coming from Cleveland Clinic. But I kind of really do like internal medicine. So I still wanted to do a fellowship, but I wasn't sure entirely what to do. I knew I wasn't great at research, and so that was kind of what I wanted to change. And it was a phenomenal opportunity to work with Dr. Gage.
Love him.
And so he's somebody, I think I met him probably 2021, about a year before I started here. And he's been a mentor, friend, guide, teacher, just about everything you could think of.
All around fabulous person.
This is my thesis. It's finally out. People kept asking me about it, so I figured I would just address the concerns here. So this was what me and Dr. Gage have been working on for the 2 years I was doing fellowship, and it kind of extended into a third year. So for all you cardiology aficionados, take a look.
So, 38-year-old male with history of alcoholic cirrhosis, presenting with epistaxis, gingival bleeding, and lower extremity swelling. Do you have anything you want to say for this? Do you want me to go to the HPI first?
I can just start with this.
Okay.
So one, it would be great if the bleeding was just due to the cirrhosis, as we know is commonly associated. So last year was my first one of these, and I came in with a tongue lesion, and it turned out to be giant cell arteritis. So what I have found is start with a really big net and then try to hone in. So going through, honestly, the majority of us, I don't think really use it too often anymore, but I find it's still helpful for cases like this. So I go through my mnemonic of Vindicated 8. So V for vascular. In terms of things that can cause bleeding is kind of the main thing I'm honed in on. So vascular causes, I like to think of Ehlers-Danlos. I like to think of factor 13 deficiency. Again, there's a reason I grouped that one, but talk about that later. And hereditary hemorrhagic telangiectasia. So basically, is there something wrong with the vessels that's making you more prone to bleed, even like a vasculitis, giant cell arteritis?
Can't give you the same one twice.
In terms of eye, so infectious, inflammatory, there are a ton of things that can cause bleeding in terms of from an infectious standpoint. We can think everything from like viruses like Ebola. We can think of things that cause hemolytic anemia like mycoplasma, babesiosis. And we can also just think of things that affect both the liver and can make you prone to losing platelets. So HIV, hepatitis, EBV, CMV, so on and so forth. There's even a few parasitic infections you can start to think of. Well, parasitic and fungus, I guess I should say. So I like to think of histoplasmosis. This one would be a bacteria, leptospirosis, and then the almighty TB. And for neoplastic, there's a ton of different things that can happen with cancers. So you can get anything from the myeloproliferative neoplasms, which are the things like polycythemia vera. You can get myelofibrosis. You can get myelodysplastic, or you can get any of the acute leukemia lymphomas, which definitely can affect your platelet account. And D for drugs, there's a lot of drugs that cause bleeding. Most of the ones we prescribe. So the aspirins, the anticoagulants, heparin, warfarin, DOAC. And I say that's probably okay for that. D, I for iatrogenic or intoxication. For iatrogenic intoxication, I also like to kind of group like environmental things here. So you can think of like brown recluse spiders. You can think of arsenic, gold poisoning. Again, I don't know what this patient's into yet, and I'm going to skip the second I. C for congenital. There's a ton of different congenital diseases. Just looking at this case, like epistaxis, gingival bleeding, that's usually more like a platelet disorder, but the things you could think about are like Bernard-Soulier, von Willebrand, Glanzmann's thrombocythemia. Forgive me if I can't pronounce that right. Uremia. And in terms of basically all the coagulation factors, we can either have a deficiency or we could even have an inhibitor. BIC, congenital, we talked about indicated. In terms of autoimmune, we've kind of discussed quite a few of them, but I'd like to think of probably the hemolytic anemias, the ITPs, the thrombotic microangiopathies. T. Toxins we kind of talked about. And then I guess the last one would be like anatomic. So cirrhosis itself can cause low thrombopoietin levels, and that could cause bleeding by itself. The same way you guys know that like portal hypertension can also lead to platelets getting stuck and causing hypersplenism. That can definitely cause decrease in platelet count that could cause bleeding. And there is such thing as left-sided portal hypertension, which is essentially like generic portal hypertension with the liver, but it's actually when the spleen gets so big it gets congested. All right, that's my big dent.
All right. Great, thank you. So going into some more information about this patient. So all of this and his symptoms started about a month ago prior to admission. That's when he was diagnosed with alcoholic cirrhosis by hepatology, actually in the outpatient setting, after he developed scleral icterus, jaundice, and abdominal distension, and he had kind of some mild thrombocytopenia around that time. They were following him just as an outpatient, but then about a week prior to admission, he began to have worsening daily epistaxis and gingival bleeding, losing up to an estimated 1 8-ounce cup of blood per day. He kind of described it as like his gums would bleed, he would hold pressure. It seemed to maybe get better and then it would just start up again no matter what he did. He was referred to hematology as an outpatient and got an actually very quickly with them. They at that point prescribed tranexamic acid for 3 days, but there wasn't much improvement. He then, on the day of admission, was seen again by his outpatient hepatologist, but because of the his thrombocytopenia was starting to worsen, all of his bleeding not getting better, and then he was starting to get some swelling as well. So they recommended that he present to the ED for more of an expedited workup.
Okay. Just out of curiosity, is this bleeding of like the gums, epistaxis, is this all like fairly within this past month, or is this even before that?
Nope, it's all been
Okay.
mostly within the past month, but worsening for the past week.
Okay. So to me, that just helps me kind of figure that if this is like a disorder of like von Willebrand's or one of those, it would be more of like an acquired and not so much something that was congenital.
Yeah. Okay, patient details for his medical history, just alcoholic cirrhosis and hypertension, no surgical history. For family history, his father had hypertension and diabetes. His mother died from pancreatic cancer. No known allergies. For his medications, he takes Lasix 20 daily, spironolactone 50 daily, and then the recently prescribed tranexamic acid 650 milligrams only for 3 days. For social history, he lives at home with his wife. He's a former smoker with a 10-pack year history, and he's been drinking for, quote, years. I didn't really see much in the chart with more quantification of that, but he had recently increased because of a death in the family. So had increased his drinking from about 3 to 4 cocktails per night up to 6 to 8 cocktails plus per night, plus 12 beers most nights.
So right off the bat, the thing that stands out the most in this, again, pancreatic cancer. This person's a male, but pancreatic cancer, you can start to think of like the BRCA mutations and things like that. Um, Somebody who's 3 to 4 cocktails, 6 to 8 cocktails, 12 beers. So, I mean, a lot of this is just screaming that the person has an alcohol use disorder.
Mhm.
In terms of alcohol, it can cause a million different bad things. It can definitely cause the cirrhosis by itself. It can be associated with just pancytopenias. It can be associated with hemolytic anemias to some degree. Um, Peripheral neuropathies, you name it. Alcohol probably can affect it poorly. So that's the biggest thing that stands out right now.
Okay. For his review of systems, no fever, chills, night sweats. He did have scleral icterus, no pulmonary symptoms, no chest pain palpitations, but he did have bilateral lower extremity edema. He had some abdominal pain, but no constipation or diarrhea. He has gingival bleeding and some petechiae over his bilateral lower extremities. He's jaundiced, and then no neuro or psych symptoms.
So looking at this stuff right now, so the scleral icterus, again, realistically, is probably from the cirrhosis itself. Bilateral lower extremity edema, for the sake of argument, just because I don't think the answer to this case will be cirrhosis. When I think of bilateral lower extremity edema, the things I like to think about are so hydrostatic problems. Hydrostatic problems would be anything from like right heart failure, essentially things that would cause like a buildup of fluid, venous insufficiency, venous clots, even pregnancy. If we're talking about oncotic issues, we can talk about whether the oncotic issues are problems in the vessels or the problems in the interstitium. So in the vessels themselves, this is kind of like our classic things that cause lower extremity edema. So nephrotic syndrome, we could talk about cirrhosis, of course, malnutrition, or like some kind of protein losing enteropathy. In terms of in the interstitial, and this is one of my pet peeves, so I'm gonna bring it up because I
Yeah.
have a mic. So I hate how often we use the term lymphedema. To me, lymphedema really should be like a non-pitting edema, and it's usually from most classically from someone who's had venous insufficiency or lower extremity edema that's been there for so long that you basically have like permanent changes and it's no longer pitting, and then you'll see all the other things that you see with venous insufficiency. So everybody loves to say lymphedema whenever we're tired of diuresing. That's just been my experience, at least on cardiology firm. And then the other things that can happen that could cause lower extremity edema due to proteins, you could even think of like thyroid disease, like glycoaminoglycans. Again, classically, that's like also behind the eyes and stuff, but you can get it on the shin. And the other things I think about with edema are just kind of like your generic things. So if you have capillary leak due to sepsis or something like that, or you have some really bad malignancy going on, or even if it's like an allergic reaction, like angioedema, again, not saying that this is what's causing that, but just walking through the lower extremity edema. So the gingival bleeding and the petechiae. So petechiae to me are basically just itty bitty bruises, classically associated with things like thrombotic microangiopathies, immune thrombocytopenic purpura. So most everything I'm seeing right now, in terms of the bleeding side, really looks more like a platelet bleeding problem, which we can kind of go through as we get more information, instead of like a coagulation factor issue, which is usually more commonly like hemarthroses and things like that.
Okay. Great. So going into physical exam, vitals pretty stable, a little bit hypertensive, 151/88, but nothing crazy. He's ill appearing, he looks cachectic, he's in no acute distress. For HE and T, he has notable scleral icterus, and the mucous membranes are notable for bleeding of the upper and lower gums. No cardiac or pulmonary findings. First abdomen was distended, mildly tender to palpation throughout all four quadrants, but no fluid wave. His skin, they noted petechiae over his bilateral lower extremities, thought it was worse on the left than the right, as well as some small bumps on his upper arms. He has dense 2+ pitting edema noted on his bilateral lower extremities, and then no neuro or psych deficits.
I know it's not highlighted, but what are small bumps on his upper arms?
They just described it as like just small little bumps is all they wrote under derm for his upper arms.
I mean, like you can get, I forget what the fancy name for it is called, but you can get like a lot of people have bumps on like their upper backside of their arms. Again, I only know the like colloquial term, which is chicken skin. But
yeah, filamentous
hyperkeratosis.
hyperkeratosis.
Say it one more time, Dr. Ed. Keratosis pilaris.
Okay.
That's why I forgot.
Okay. Next, we just have the initial labs, and then we'll see what else you would want. So for his initial, mildly hyponatremic at 134, phos low at 1.8, calcium was 8.3, his T-Billy was 8, direct 1.8, protein low at 6, albumin low at 2.6, and AST and ALT mildly or elevated at 134 and 60.
Okay.
And then,
I was just gonna say for this first part, basically sodium, potassium chloride, CO2 is a little bit higher than what I'd expect. I'd be expected a little bit closer to 24. Mag, phos, and calcium are all kind of like on the bubble for abnormality. This is also one, just looking at the ALT, if you've rounded with me, you know this is something that I like to preach and annoy people about, is that ALT that's posted in Epic, it usually goes up to like 55. That's not really a normal ALT. A normal ALT is probably closer to about 20 to 25 for women and 30 for men. So this is already double upper limit of normal for me. Realistically though, he has cirrhosis, so he probably has some kind of inflammation, alcohol. You have an elevated AST to ALT ratio that's more than double, again, just consistent with alcohol liver disease. You have quite a bit of total bili versus direct bili. I'm gonna think on that one a little bit more. And then in terms of protein albumin, seeing a little bit of a gap. So that starts to make me think of things like amyloidosis, plasma cell dyscrasias, something that's producing too much protein. And then CBC, hemoglobin 9.4, not too bad, honestly. Platelets are 80, MCV is 89, and ANC is 3.3. Is there any more labs that are about to come up?
normal diff.
Normal diff. Okay. Um, while it's on my mind, probably the biggest things I'd want at some point would be my concern right now is kind of the platelets. So you can do like platelet function analyzers. You can do platelet aggregation assays. Just in terms of the low hemoglobin, MCV is basically normal. So for a normocytic anemia, I try to think whether it's hypo or hyperproliferative. So I'd want a retic count. Hypoproliferative would be anything from like aplastic anemias to medications, toxins. In terms of hyperproliferative, that would basically just be consistent with somebody who's bleeding. So if someone's having active bleeding, has hypersplenism, has hemorrhage, those are all kind of the classic things. Again, right now everything seems like pretty minimal bleeding. Um, and the other thing I was looking for was possibly like a pancytopenia, but this mostly just looks like anemia and platelets itself. Um, Again, you could also start to think of some of the hemolytic anemias. I think Evans syndrome off the top of my head, but
Okay.
that's what I got so far.
Okay. So I heard you talking about wanting to, investigate really with more of the hematology labs and some platelets. Anything else diagnostic that you would want for this patient at this time, to kind of help lead you one way or the other?
So in terms of just going through the hematology ones first while it's fresh. So I definitely would want a retic count.
Mhm.
I definitely want LDH, haptoglobin, serum platelet function assay, or platelet aggregation assay. Probably the easier version of that, though, is just a peripheral smear.
Mhm.
Um, the platelets themselves, again, even though the patient has cirrhosis and it makes sense for them to have low platelets, you could always get a citrated platelet count to make sure it's not like a pseudo thrombocytopenia. Um, PT and INR definitely would be helpful. If we really get down the bleeding kind of rabbit hole,
Mhm.
you can start to think of things like thrombin time, um, bone marrow biopsy. I feel like that's gonna happen eventually, but that's just a guess. Flow cytometry. And I'd say that's probably, I'm sure I'll think of more as we go on. In terms of diagnostics, this was just more of something how I was trained, and it's not something that's necessarily done. I'd question, in somebody who's only like 39, again, there is a lot of alcohol history, but I'm still concerned that the cirrhosis may or may not be due to alcohol. Um, where I trained, everyone got a biopsy. Here, it's usually more of like just an MRI, just to kind of look for something else. Um, and honestly, probably just abdominal imaging in general would probably be very helpful. Just that way I could get an idea of how big the spleen is, how big the liver is, if and if there's any problems with the vessels themselves. So
Okay. So, um, we can start with the anemia workup because that's what we're really wanting. So, we weren't able to get a full iron panel. There was some hemolyzing going on, but ferritin elevated at 2,500. Iron was 135. They did B12 and folate as well, which were both normal. His hapto was less than 10, but they did a direct Coombs, which was negative, and his LDH was 449. They got the peripheral smear and the reticulocyte count that you requested as well. Um, the platelet estimate on the peripheral smear was decreased. There were no schistocytes seen, and a few abnormalities with the red blood cells, and the retic count was 2.7. And then the coags you requested, his PT was 22.9, INR 2.1, and PTT was 37.
okay,
They did not do any other testing for platelets besides that.
gasp. Okay. So going through these one by one, the it's funny that the TIBC and TSAT are both
Yeah.
hemolyzed.
And they never rechecked
Um,
it.
so again, I get a lot of people and talking about iron deficiency, whether it's in clinic or whether it's an inpatient. The ferritin is obviously an acute phase reactant, and so it can really kind of change its value quite a bit just based on what's going on. You can have everything from like Still's disease, where it's like tens of thousands high. The classic thing I usually think about, and this patient's creatinine was normal off the top of my
Yep.
head. So long as someone doesn't have heart failure and doesn't have end stage renal disease, I usually use my ferritin to kind of help me figure out whether I think this is iron deficiency or not. Again, it's not perfect, but in studies that I've read about where they compare um, ferritin to like hemosiderin stained bone marrow,
Hmm.
usually what I found was that if your ferritin's above 100, you probably don't have iron deficiency anemia unless you have some really weird cause to have high ferritin or end stage renal disease because they shoot for like a ferritin of like 700. If your ferritin's below 15 to 30, then it's probably pretty consistent with iron deficiency. And if you're in between, you know, if you want to give iron, go for it. It's usually the way I look at it. This would be less consistent with iron deficiency. The B12 is super high. I think that's a high folate.
Hmm.
Okay, cool. So in terms of anemias, again, it didn't really make a lot of sense for it to be like a megaloblastic or non-megaloblastic macrocytic anemia. Um, at least from megaloblastic side, B12 and folate are normal. The other things you could consider are like copper, zinc. From the non-megaloblastic side, you could start to think of like the myelodysplastic diseases or just an elevated MCV in the setting of cirrhosis, but MCV was normal. And to be honest, do we get indirect Coombs?
Nope.
Yeah, it's fine.
Just the
Um,
direct.
None of this really is consistent with like so much hemolytic anemia. The thing that stands out to me the most, and again, I don't have a calculator right now to look at the hematocrit, but I'm assuming this is a low retic for
Yeah.
what it is, the
Yep.
degree of anemia.
Hyperproliferative.
So a hyperproliferative, the thing that's also a little bit interesting to me is that you have target cells. It's not something you see super, super often.
Hmm.
Um, Classically, that's associated more with like the thalassemias. Again, thalassemias definitely can cause increase in bleeding, but it's not really something I'm expecting for these symptoms. And I know I was the one who asked for the INR, but full disclosure, if the patient truly is cirrhotic and we have no question, which I don't know if we do, but if the patient's truly cirrhotic, INRs, you can throw it out the window. Um, Patients with cirrhosis have problems with their coagulation cofactors and their anticoagulation cofactors like protein CNS. So INR pretty consistently isn't really indicative of bleeding in this population. That's why we don't really have to check it before a paracentesis or something like that. Um, yeah.
Okay. The other thing I heard you mention was some imaging specifically to look at the spleen and if there's any clots or anything like that. He had four different imaging. I just kind of put it all together into one. Nothing super exciting. They did an ultrasound of the liver. There was findings of cirrhosis, no clot that was seen, and some ascites. His CT abdomen pelvis, again, findings of cirrhosis, ascites, and maybe some portal hypertension. They did the liver Doppler, but there's no evidence of hypersplenism. They did the duplex ultrasound on his legs just because they were swollen when he came in, but no evidence of DVT. And he got an EGD as well, which was normal, and he had no evidence of varices.
Interesting. So that rules out quite a few number of things. So in terms of thrombotic diseases, I don't think we actually went over his meds. I don't know if they were super relevant.
He was only on spironolactone and
Spironolactone.
Lasix, and then 3 days of tranexamic acid. That was it for his meds.
And any heparin when they get in the hospital.
Nope.
So right off the bat, with a lot of bleeding disorders can come thromboses, especially the leukemias and lymphomas. Again, the DVT doesn't really rule out anything, but makes it a little bit less likely. In terms of the CT abdomen, this really just looks like essentially just cirrhosis.
Mhm.
And you have no evidence of hypersplenism. So a bigger spleen can be associated with anything from like Gaucher's disease, Niemann-Pick. The reason I'm saying those is because I had a patient with that recently. Um, a lot of different types of infections, particularly like mononucleosis, EBV. Um, the other things I'd consider are just leukemias and lymphomas and myeloproliferative neoplasms. And EGD, just nice that he doesn't have varices, so probably not too bad. Portal hypertension. That's pretty much all I got for the imaging.
So I guess thinking about like his initial presentation with the bleeding and the gingival bleeding, and now having more information with his platelets, his spleen, everything like that. Does that help you kind of, you had the great vindicate? Does that help you rule things in versus out? Or are there other pathways you would want to go down?
I mean, right now, so I'm not thinking as much about the congenital diseases. I'd say probably our vascular abnormalities, Ehlers-Danlos, HHT are still possible, but again, I would expect those to have bleeding throughout his life.
Hmm.
Um, Infection is definitely still high on the differential. You can think of like all those different viruses we discussed, mycoplasma, but I'd expect more to have like an autoimmune hemolytic anemia associated with the majority of those. Um, you can even think of things like tick-borne diseases, now that I'm kind of expanding a little bit farther. Um, I'd say probably, and again, I don't know how if we have these studies readily available, but probably the things I would focus on in terms of platelets, because that kind of seems the thing that's sticking out the most. I try to think of the things that cause problems with platelet adhesion. So platelet adhesion would be von Willebrand's and Bernard Soulier. I think I'm saying that right. Which is the receptor deficiency in GP1B. Um, you can think of secretion. So he didn't have any uremia. Um, you could even go like really far deep, and there's like storage pool diseases like gray platelet syndrome, things like that. And in terms of the other things that classically, again, he's not on any of the common medications that interfere with ADP or in terms of antiplatelets or anticoagulants. Um, and then problems with like platelet aggregation. I don't think we got a D dimer, but none of that really looks super
Mm-mm.
consistent with like a DIC
Yeah.
picture or anything like that.
And there were no schistocytes.
Yeah, no schistose.
Mhm. Well, I can give you an infectious eval because you mentioned that a couple times. Overall, I mean, negative RP, blood cultures, HIV, all negative. His Hep A IgG was positive, but IgM was negative. The rest of all of his hepatitis B serologies and his hepatitis C were negative.
Hmm.
And then you had mentioned other ones. The only other ones that they checked at this time was Parvo and Ehrlichia, and both of those were negative. They did not check at any point mycoplasma on
Anaplasma?
him. Nope. They ended up doing the CMV and EBV, but that was not at this time, so I didn't include them.
Okay. So thinking through this a little bit more. So nothing really screaming out infections, mostly just target cells and low platelets. In terms of things that can cause low platelets, to be honest, they're not really that low. And all.
Yeah.
Um,
Would you, and I guess my other question, would you expect this amount of bleeding with like that level of
no,
platelets?
definitely
Yeah.
not.
Yeah.
And so the fact that usually when we have bleeding, especially like spontaneous bleeding, like epistaxis and that kind of thing, usually we're talking about platelets less than 50, even maybe less than 30. Um, I'm starting to think a little bit more about some of the thrombotic microangiopathies. So again, E. coli and in terms of hemolytic uremic syndrome, but we don't really have the other symptoms support that of like fevers.
Nope.
TTP, again, you can get like acquired Adams TS13 deficiencies and things like that. In terms of really what I'm starting to wonder more is there a problem with the platelet function itself? Because we're still having bleeding, but our quantity isn't really super decreased. And so problems with platelet function could be the syndromes that are similar, like Glanzmann's or Bernard-Soulier, or it could just be due to an inhibitor of some type or von Willebrand.
Mhm.
And then if we're like really completely out of luck and like we've done everything, we have petechiae, we have kind of low platelets. Again, I don't think it really explains the degree of bleeding. ITP is kind of more like something you rule out. It's like a diagnosis of exclusion.
Mhm.
So I'm more curious about how well the platelets are working right now.
Okay. Are there any other things besides like the platelet function that could be contributing to his symptoms or that you'd be worried about in um, like an alcoholic patient like this?
Um, I'd say probably some of this stuff we can also start to consider is, I mean, I saw on the previous page, like, honestly, just doing urine studies, I think is fair at this point. Just starting with a UA, urine protein, and just seeing if we see anything that kind of leads us to believe that there's some kind of kidney involvement.
Yeah.
That'd probably be where I go next.
Okay. His UA, he had 1+ protein for urobilinogen, but everything else was pretty negative.
Yeah.
They did a UDS, which was negative, and then they did actually end up doing a 24-hour urine protein collection as well as a spot protein creatinine ratio, all of which were pretty normal.
Okay. So digging into some of the bag of tricks then, I'm gonna start shotgunning a little bit more.
Okay.
So in terms of rheumatologic things, again, kind of like what we always joke about, but lupus can kind of do whatever it wants. So we can consider doing ANA and ENA panel. Um, in general, though, it's kind of uniquely associated with the platelets.
Mhm.
And in our infectious workup, do we have HIV?
It was negative.
Okay, cool.
Mhm.
Um, so we can start looking at some of the rheumatology labs. I don't think it's going to come back with anything though. Full disclosure.
Yeah, they you had mentioned the protein gap earlier. They did send off kappa lambda. Ratio was normal, UPEP was negative. ANA is a little 1 to 160, but they did not do an ENA or anything else. They just did the mitochondrial antibody and smooth muscle antibodies, which were negative.
Mm, and not presenting with any fevers or anything.
Nope.
Can we get an echo just to see if there's like an obvious vegetation or something? Again, there are some of the more indolent endocarditis. Nothing.
It was beautiful. I think it was the best read I've ever seen.
Still leaning toward these platelets then.
Yeah.
Um,
And I guess like one thing you had talked about earlier too and brought up was like nutritional stuff. You talked about like ceruloplasmin and copper and stuff. Could
so
kind of why did that come to your mind?
there definitely can be quite a few different nutritional deficiencies that can kind of lead to bleeding. One in particular that could happen would be something like scurvy and vitamin C deficiency. It's very uncommon in
Mhm.
somebody who's kind of, I'm assuming this patient's from the States and normal BMI.
He had been losing weight and was pretty cachectic looking on
Okay.
admission.
So we've already kind of talked about some of the different nutritional stuff in terms of folate, B12. I don't think we've checked copper and zinc. Technically, vitamin E issues can be associated with a lot of bleeding, and vitamin C in particular.
Mhm.
Did we check any of those?
We did check those. His vitamin C was undetectable. Vitamin A was less than 5, his copper was low at 0.6, and his vitamin D was 8.
Okay, so maybe some vitamin C stuff. So classically, scurvy, they also have problems with their hair, and
Hmm.
they can have increase in bleeding and things like that too. Um, I don't actually know. How accurate is a vitamin C level?
According to what I read, pretty accurate if it's less than 0.2. And this was less than 0.1 on our labs.
Okay. So yeah, it should
Yes,
be around the hair.
I think so.
Okay.
Hmm.
So maybe
All they ever wrote in any of the notes was petechiae, and I couldn't find a picture. I was hoping I could find a picture to put in there for you.
okay, cool. Um,
Okay.
is there any
So,
other pathway I should be going down next? So, the only thing that's really come back positive was not a ton of platelets,
mhm,
persistent bleeding. They didn't do any of my platelet function assay stuff.
they did
A
not.
little salty, but
Yeah.
um, yeah. So this is kind of an interesting case because it looks like this all really just stemmed from a vitamin deficiency. It's still not that common, but again, cirrhosis being like kind of like a catabolic disease, they get a lot of protein wasting in general. So, uh,
Yeah.
sounds like what it's gonna be, but maybe you'll surprise me.
Yeah. Answer was scurvy for all of his symptoms, secondary to malnutrition from his excessive alcohol use, but also some cirrhosis related coagulopathy. So a little bit multifactorial, but the new symptoms he was having within the last week to couple weeks, they attributed all to scurvy. So the rest of his hospital case, GI was consulted. Kind of as you said, they agreed they did not feel that his degree of thrombocytopenia was related to his underlying liver disease, and there was no hypersplenism, which also helped them think like this thrombocytopenia is not us. They also didn't think that his bleeding symptoms were consistent with the degree of cirrhosis and liver disease, because after his initial presentation, at least his cirrhosis and liver disease symptoms seemed to be improving. Heme was then consulted. They didn't say much in the note, basically just said don't do any more tranexamic acid because there's a risk of thrombosis and just kind of left it at that. So it was actually his primary team. So his intern who did further investigation because of this weird presentation sent off the nutritional labs and got all of those back. He was seen by dietitian. His diet improved. He followed up with this PCP. He was still having some bleeding, but everything was improving quite a bit. He also was able to abstain from alcohol and do better with that. And he is currently undergoing transplant eval with hepatology. So, just some teaching points. Patients with alcohol use disorder at an increased risk for nutritional deficiencies in general. I know we always think about starting them on a multivitamin or thiamine when they come in, but it's also important just to not forget about that with any complaint they present with. Bleeding symptoms and vitamin C deficiency happen because of impaired collagen synthesis, causing vascular fragility. And it's mostly cutaneous signs. So, like the petechiae, parafollicular hemorrhage, bruising is probably what they were all seeing on his legs. The gingivitis, they usually have some arthralgias, which he didn't, impaired wound healing. And the bleeding basically happens, especially with the gums, because there's so much vascular fragility that anytime he had any bump on his gums, then they would start to bleed. In the US, as you were mentioning, it's pretty rare here, but usually in severely malnourished individuals, those with drug and alcohol use disorders, history of bariatric surgery, living in poverty, or on diets devoid of fruits and veggies. And then the last thing that was never really addressed during his hospitalization was this um, low hemolysis. And from some case reports I was reading, it seems like scurvy can cause anemia with lab values that mimic hemolysis due to some impaired erythropoiesis, but true hemolysis is extremely rare. And that's our case. Thank you so much, Dr. Montane.